This presentation is on the Hi-OxSR sequential rebreather and its use as a novel treatment for long COVID-associated cognitive dysfunction. The presentation will discuss the mechanism from COVID that may be responsible for the cognitive dysfunction, the prevalence and significance of the dysfunction, and then how the Hi-OxSR may be able to reduce the dysfunction. As most of you know, having had long COVID for an extended period, some of what I will discuss is not new to you. COVID is primarily a vascular inflammatory disease that can affect multiple organ systems, including the heart, lungs, kidneys, gastrointestinal, blood clotting, and the brain and nervous systems. The focus with our work is targeted at its effects on the brain. Long COVID is estimated to affect more than 17 million Americans, which, considering the presentation of cognitive dysfunction, is probably a significant underestimation of its impact. The United Kingdom has a program called Biobank, in which they collect massive amounts of data on many diseases, including COVID and post-COVID cognitive dysfunction. Some of their data presented here for memory function and brain fog show that people with persistent long COVID, the red squares, as well as those who have fully recovered, the yellow squares, have significantly lower performance than people who have never had COVID. The decrease is estimated to correlate with a 3 to 9 point decrease in IQ. This was reflected in a greater loss of grey matter on MRI. Note that only 4% of the population with post-COVID cognitive decline had been hospitalised for COVID. A 2024 report on people with difficulty in remembering and concentrating or making decisions saw a significant increase in younger people. This is a major concern, as older people may just say, "I'm just getting old, and that's why I can't remember," while it's actually the effects of COVID. Most people don't ask themselves daily, "How fast am I thinking?" For young people with loss of executive function, it may not affect who they are, but might affect who they could have been. COVID is known to inflame blood vessels. The inflamed vessels in the brain narrow and reduce blood flow to the brain. As shown in the images on the right, a simple halving of a vessel's diameter will increase the resistance 16-fold. That means for the same blood pressure driving force, the blood flow to the brain can decrease to 1/16 the previous flow. This reduction in flow can starve brain cells from oxygen and nutrients. However, there are ways to alter blood flow to the brain. Carbon dioxide in the blood is a major controller of cerebral blood flow and oxygen delivery to the brain. As seen in this data, increasing CO2 from a normal resting level of 40 torr on the horizontal axis, the blue lines, to 50 torr. The green lines significantly increases oxygen and nutrient delivery to the brain on the vertical axis. Note that many patients with long COVID, as shown with the red lines, have lower than normal carbon dioxide levels, further impairing cerebral blood flow, and therefore have a greater potential to increase oxygen delivery. The Hi-Ox was originally developed more than 25 years ago for two purposes, including for the delivery of extremely high oxygen concentrations at low oxygen flows and to contain exhaled viral particles during pandemics, starting with the bird flu outbreak in 2003, which primarily was in Canada. Because the Hi-Ox mask does not have exhalation holes in the mask, it also prevents dilution of oxygen when you inhale, significantly increasing the concentration of oxygen it can deliver at the same oxygen flow. You can see from the graph on the right, when compared to a non-rebreathing oxygen mask, the grey bars, which is considered a high oxygen delivery mask, at resting ventilation, the Hi-Ox, the green bars, delivers more than 30% more oxygen at the same oxygen flow. And when a patient doubles their ventilation, the difference grows to 40% more oxygen with the Hi-Ox. The lower left image demonstrates that by directing the exhalation down a separate pathway, It can capture particles in a filter that are normally exhaled out the side of the standard mask towards healthcare workers. I will now describe how, with use of the Hi-OxSR, we are able to improve cerebral blood flow. The Hi-OxSR was originally developed as a diagnostic tool for evaluating how the blood vessels in the brain and eye reacted to stimulation. This became part of the workup for brain tumours and stroke management. By controlling the CO2 in the patient's blood, we were able to rapidly change cerebral blood flow. In this image, the circles in the figure are the exhaled CO2 concentration, and solid line trace represents changes in cerebral blood flow. If you look at the timeline, you can see that within seconds of changing the CO2, the blood flow to the brain rapidly responded. This slide is from work done using an ultrasonic transducer to measure cerebral blood flow. The first image on the left is the blood flow during quiet breathing with a normal CO2. Each wave is a heartbeat, and the area under each wave represents the volume of blood going to the brain. In the middle image, you can see that when the CO2 falls because of deep breathing, there is a dramatic fall in blood flow to the brain. Notice the significant reduction in the area under the curve. In the third image, there is a clear and significant improvement in cerebral blood flow, even while maintaining the same deep breathing. However, this is with rebreathing of CO2 to bring cerebral blood flow back up. A brief report from Germany in 2021 that treated 2 women with post-COVID cognitive dysfunction with electrical stimulation and cleared their brain fog was attributed to improvement in cerebral blood flow. Since we were able to cycle CO2 up and down for the diagnostic application, we considered just turning it up for a prolonged period to see if it would have an effect in long COVID patients. 5 people with long COVID volunteered to be prescribed treatment with the Hi-OxSR for 30 minutes twice a day for 14 days. All 5 improved both in objective scoring on the SAGE test as well as reported subjective improvement. 2 people requested a second 2-week treatment and with further improvement. Now, more than 2 years later, all 5 have maintained the improvement. The physician who heads the long COVID program for all of Canada ran a pilot study with treatment for 14 days. The participants were tested at baseline and then again at the end of treatment on day 15, and then they came back 30 days later for repeat testing to explore whether any improvement was maintained. The tests included 7 measurements of memory and executive function, and 1 brain fog questionnaire that evaluated their quality of life. On these graphs, the people indicated with the gold lines are those that improved. 75 to 80% of the people improved during the 14-day treatment period, and several of them found further gains 30 days later. Note that for the executive function testing, higher number are better performance. For the quality of life brain fog questionnaire, a lower number is better. You can see that the treatment was not loved by everyone, and the quality of life for some people was slightly worse on day 15. However, 30 days later, there was a dramatic improvement in their quality of life. So why does breathing carbon dioxide improve cognition? As I previously showed that increasing CO2 increases oxygen delivery, it's because it can increase cerebral blood flow by 20 to 60%. There are also other possible mechanisms that can address cognitive function. CO2 has some anti-inflammatory properties, and since COVID is an inflammatory disease, whatever anti-inflammatory activity is provided by the CO2 would be beneficial. Additionally, CO2 can upregulate serotonin in the brain. It is known that people with long COVID have reduced serotonin in their gut, and with the gut-brain relationship, increasing serotonin in the brain might also be beneficial for influencing a sense of well-being. These images explain the movement of oxygen and carbon dioxide during breathing. Carbon dioxide is a byproduct of the body's metabolism. It's produced by the cells in the body and returned to the lungs to be exhaled. It is also the molecule that makes you breathe. The higher the CO2, the more your brain will drive your ventilation. When breathing room air, as in the first image, you inhale approximately 21% oxygen and nearly zero CO2. At the end of inhalation, the air in your alveoli contain approximately 5% CO2, which was returned to the lungs from the body cells, and the blood removes the oxygen it requires, leaving around 16% oxygen in the alveoli. The middle image shows what happens when you exhale the first breath into the rebreathing tube. At the end of the exhalation, the composition of the air in the airways, mouth and part of the tube is air from the alveoli. This air contains approximately 5% CO2 and 16% oxygen. On the next breath from the Hi-OxSR, the very first air that enters the airway is approximately 98% oxygen, and this is carried into the alveoli to be transferred to the blood. That oxygen is followed by the air that was collected by the rebreathing tube, which contains approximately 5% CO2 and 93% oxygen. Thereafter, at the end of every breath, the airways and rebreathing tube will be filled with air containing higher CO2 and higher oxygen than breathing room air. And since not all of the CO2 is exhaled, the level of CO2 in the blood will increase. The level of increase is controlled by the flow rate of oxygen into the circuit. The higher the oxygen flow, the less rebreathing, and the less the CO2 will rise. The Hi-OxSR has several unique features that enables providing CO2 in the inspired air without using an external tank of CO2 by using your own exhaled CO2. For effective treatment, the mask needs to seal tightly to the face. Therefore, the mask has dual head straps and foam around the nose to create a tight seal. It has no holes in the mask as is found in usual oxygen masks, so that there is no dilution with room air when you breathe in. There are multiple valves in the mask to control the flow of air, including a valve to allow exhalation into the rebreathing tube and a sequential dilution valve that enables inhalation of the exhaled air sequentially after inhaling the oxygen in the oxygen reservoir bag. When you breathe out, your exhaled air, the red arrow, flows out the exhalation valve into the rebreathing tube. Oxygen from the oxygen concentrator, the green arrows, flows into the oxygen reservoir bag and closes the sequential dilution valve. The end of the exhaled air in the rebreathing tube contains air from your alveoli, your air sacs, which is high in CO2 and still high in oxygen. The reason that the rebreathing tube is long is that we need to keep your exhaled air in a linear arrangement so that the air from your alveoli is closest to the valve, and you inhale air with high CO2 and oxygen concentrations. When you start to breathe in, the first air into the mask and your lungs is 97 to 100% oxygen from the reservoir bag and the continuous flow from the concentrator. Although the oxygen flow to the mask is only 2 litres per minute, your body uses only around 0.35 litres per minute. You inhale more than 6 times the volume of oxygen your body needs. Once you've inhaled the small volume of oxygen from the oxygen reservoir bag, it collapses and the sequential dilution valve opens. You can then inhale the air from the last breath you exhaled, which contains a high concentration of CO2 and oxygen. This will raise the level of the CO2 in your blood being pumped to your brain. To use the Hi-OxSR, besides the mask and rebreathing tube, you will need an oxygen concentrator. It needs to be a continuous flow machine that can deliver 2 to 5 litres per minute. The treatment uses 2 litres per minute. However, your physician may want you to breathe a higher level of oxygen before or after treatment. If needed, the 5 litres per minute will provide significantly more oxygen. You can't use a pulse delivery machine that delivers a bolus of oxygen on each breath. You also need a pulse oximeter. Because CO2 is the gas that drives your breathing, this treatment will make you breathe much deeper and faster than you normally do. Somewhat like you are running a race, sitting in your chair. Therefore, you might have a sense that you are not getting enough oxygen. Your oxygen saturation will actually go up during the treatment, and the pulse oximeter will reassure you that you are getting enough oxygen. It is also a safety alert if the tubing between the oxygen concentrator and the Hi-Ox pops off the connector, in which case your oxygen saturation might fall. You need to make certain that there is no leak around the edges of the mask. If your breathing doesn't increase, you probably have a leak. While it's not the most comfortable treatment, and as I previously mentioned, several patients felt worse during the treatment, they found it worth the discomfort, considering the significant benefit. Sitting back and taking pressure off your diaphragm will usually be more comfortable. The treatment system uses all FDA-cleared devices. Both the Hi-Ox mask with the sequential rebreathing valve and the rebreathing tube are FDA listed. Unlike drugs, the FDA doesn't approve devices. They only clear devices for sale. Most oxygen concentrators are FDA cleared under 510(k) regulations. All of these require a physician prescription to purchase. However, you can find lower-cost oxygen concentrators on the market that are not FDA cleared, but FDA clearance does assure a certain level of known quality. The Hi-Ox rebreathing device, although cleared for oxygen delivery, which it does, and for rebreathing your exhaled air, it is not specifically cleared for the treatment of long COVID. Oxygen and its approval is given to patients who need oxygen, not based on a specific disease. For example, the drug Minipress is approved for lowering blood pressure, but is also used for treating nightmares. As with all medications and treatments, there are always potential adverse events or side effects. These are some of the reported adverse events or side effects that have been reported by people who have used the rebreathing system. The significant increase in cerebral blood flow from the CO2 can cause a headache, which usually diminishes shortly after treatment completion, although it can last longer. Some people with a history of asthma have reported wheezing during the treatment. Although you are not running, the treatment drives you to breathe heavily, as if you were running. This increased airflow can cause a cooling effect, which may trigger wheezing similar to exercise-induced asthma. People with a history of asthma should check with their doctor as to whether they should take an inhaled bronchodilator or other medication prior to using the rebreather. Some people with chronic obstructive pulmonary disease have breathing limitations and may not respond to the CO2 or have increased CO2 in their blood without rebreathing. People with COPD should check with their doctor before using the rebreather. Nausea has been reported. Although the mechanism causing nausea is not obvious, it may be related to swallowing air. It is usually a temporary effect. Fatigue and post-exertional malaise, or PM, may be different levels of the same response of the body to the heavy breathing. A few people have reported a PEM crash after treatment. This side effect can be significant and impact on the ability to continue treatment. We are exploring use of just oxygen following treatment to minimize this side effect. Remembering that the response to rebreathing is very rapid, it may be possible to use the rebreather more often, but for shorter periods. This has not been tested as yet. Thank you for watching this video. If you have questions, you can email me at alex.stensler@twelfthmantech.com. These are references to some of the work published on the technology and background physiology.